Hello. Today I will review the updated guidelines to reduce venous thromboembolism in trauma patients, a Western Trauma Association critical decisions algorithm. This article was published in the Journal of Trauma and Acute Care Surgery in November 2020. Deep vein thrombosis and pulmonary embolisms are potentially preventable complications after trauma. This algorithm is on optimizing the delivery of pharmacologic prophylaxis to prevent VTE and minimize associated complications. The goal of this paper is to provide updated guidelines that apply to most patients most of the time. A 1994 study found the DVT rate of the lower extremity was 58% in severely injured trauma patients. A 1996 study found that 30 milligrams of subcutaneous enoxaparin twice daily performed better than 5,000 units of heparin twice daily in reducing the incidence of DVT in moderately and severely injured trauma patients. In that study, enoxaparin was started within 36 hours of injury and continued through all procedures except spinal fixation surgery, in which a single dose was held preoperatively. This is the algorithm in its entirety. I will go through each letter decision point that corresponds with the paper, starting with the letter A and ending with the letter L. At point A, this algorithm is intended for adult trauma patients, therefore those patients are 18 years and older. For younger patients, you can refer to the Joint Practice Management Guideline for the Pediatric Trauma Society and the Eastern Association for the Surgery of Trauma, which recommends pharmacologic prophylaxis be considered for children older than 15 years old and in younger postpubertal children with injury severity scores greater than 25. Point B states that you should assess the risk of VTE in the patient. In general, a patient with an ISS of 10 or more should be started on pharmacologic prophylaxis as soon as possible, whereas an ISS less than 10 are at lower VTE risk and may not require pharmacologic prophylaxis. Patients with spine or pelvic fractures, repair of venous injury, a history of VTE, or inherited clotting disorders have increased VTE risk and should be considered for pharmacologic prophylaxis. Independent predictors of increased VTE risk are increased age, obesity, and lower extremity fractures. Any combination of these should encourage initiation of pharmacologic prophylaxis. Point C states that patients with minor trauma may not require pharmacologic prophylaxis. The paper states there is pain with injection, potential for hematoma, and the cost of medication. Therefore, avoiding pharmacologic prophylaxis may be indicated in select minor trauma patients. The trauma embolic scoring system can be used to assess VTE risk, as patients with low scores may not require pharmacologic prophylaxis because of the low VTE rate. Trauma patients that are ambulatory and have short stays less than 24 hours may not require prophylaxis, but if they are confined to a bed because of intoxication, restraints, or other reasons, or they are hospitalized for more than 24 hours, then they should receive pharmacologic prophylaxis. For the patients who do not receive pharmacologic prophylaxis, mechanical prophylaxis and/or aspirin are low-cost and low-morbidity options. Based on the trauma embolic scoring system, a score of 0 to 2 indicates no risk, and in these patients, no prophylaxis was required. A score of 3 to 6 is considered low risk, and these patients received venous compression boots. And patients with a score greater than 7 are considered to be at moderate to high risk for VTE. And as such, both venous compression devices and prophylactic anticoagulation with low molecular weight heparin is recommended. In those patients who could not be prophylactically anticoagulated for more than 48 hours due to their injuries, the insertion of a temporary vena cava filter is considered for VTE prophylaxis. A little bit more on the trauma embolic scoring system, also known as TESS or TESS. The article cited is by Rogers et al. And was a 2012 East poster paper published in the Journal of Trauma and Acute Care Surgery in August of 2012. The TESS score ranges from 0 to 14. The components are age, ISS, obesity, ventilation days, and lower extremity fractures. The article by Rogers et al. Appears to use ventilation greater than 3 days, yet I did not see this designation when I was reviewing other papers regarding the time on the ventilator in relation to the test. A score of 0 to 2 indicates no risk. In those patients, no prophylaxis was required. Again, a score of 3 to 6, they used the venous compression boots, and a score from 7 to 14, they used venous compression boots or pharmacologic prophylaxis or an IVC filter. This is a slide to give you an idea where we are in the algorithm. Appropriate delays in pharmacologic prophylaxis may occur for those patients with an active bleed, coagulopathy, hemodynamic instability, solid organ injury, or traumatic brain injury or spinal trauma. Examples of ongoing bleed noted in the paper is if there's a drop in hemoglobin greater than 2 grams within 12 hours or ongoing blood transfusion. They state that viscoelastic assay may be a good way to measure coagulopathy, yet deferring prophylaxis during trauma-induced coagulopathy is associated with increased VTE rates. For solid organ injury, early pharmacologic prophylaxis within 12 to 24 hours appeared to be safe across moderate-grade solid organ injuries such as the liver, spleen, and/or kidney, without an increased risk of bleeding. Although patients with grade 4 and 5 injuries should be approached with caution, pharmacologic prophylaxis may be initiated within 24 hours for most patients with solid organ injury. For TBI patients, they state that patients with cerebral contusion, localized petechial hemorrhages, or diffuse axonal damage may safely receive pharmacologic prophylaxis without delay. For patients with other forms of brain injury, TBI progression on the follow-up CT should warrant holding pharmacologic prophylaxis until a follow-up CT demonstrates no progression. If the follow-up CT demonstrates no TBI progression, then pharmacologic prophylaxis should be initiated. For patients with spinal trauma, they recommend beginning pharmacologic prophylaxis as soon as possible for patients with spinal injuries or after spinal surgery. Pharmacologic prophylaxis initiated within 48 hours of operative fixation of traumatic spine fractures did not increase the risk of bleeding, progression of neurologic injury, or postoperative complications, including spinal hematoma. For point E, mechanical prophylaxis for moderate to high VTE risk patients is encouraged, regardless of concurrent pharmacologic prophylaxis. For patients who are not started immediately on pharmacologic prophylaxis, mechanical prophylaxis with intermittent pneumatic compression or mobilization, when possible, should be encouraged. Point F, weekly venous compression duplex should be considered in patients at higher VTE risk who cannot be started or maintained on pharmacologic prophylaxis. Routine surveillance with venous compression duplex is not indicated or feasible for all trauma patients, yet for trauma patients with high VTE risk, routine surveillance duplex is associated with a reduced PE rate. The Greenfield risk assessment profile can identify which trauma patients may benefit from routine surveillance. This is the Greenfield risk assessment profile. Using a cutoff score of 5, the risk assessment profile successfully identified a group of patients whose incidence of thromboembolism was 2 to 3 times greater than reported in the literature. For point G, as mentioned in E, delays may occur in patients with active bleeding, coagulopathy, hemodynamic instability, solid organ injury, TBI, or spinal trauma. Chemical prophylaxis should be initiated within 24 hours in most cases and within 72 hours in nearly all cases. The practice of withholding prophylaxis prior to surgical procedures is generally not supported. Patients who underwent elective hip surgery who received low molecular weight heparin approximately 6 hours before surgery had a lower rate of proximal DVT without increasing major, minor, or trivial bleeding rates. This benefit was not observed when low molecular weight heparin was provided 12 hours or more preoperatively. Enoxaparin is the preferred medication due to its increased bioavailability, longer plasma half-life, and more predictable pharmacodynamics and pharmacokinetics when compared to unfractionated heparin. It additionally interacts less with platelets, has a lower incidence of HIT, and is not associated with osteoporosis, unlike unfractionated heparin. The recommended dose is 40 milligrams twice daily for patients 18 to 65 years who have a creatinine clearance greater than 60 and who are greater than 50 kilograms. The recommended dose is 30 milligrams twice daily for patients older than 65, have a creatinine clearance 30 to 60 milligrams, or are less than 50 kilograms. Additional ways suggested in the paper to dose heparin is based on a weight of using either 0.5 or 0.6 milligrams per kilogram BID, or 30 milligrams BID for patients weighing 50 to 60 kilograms, 40 milligrams BID for patients weighing 61 to 99 kilograms, and 50 milligrams BID for patients weighing greater than 100 kilograms. They say that patients receiving higher doses based on weight should be monitored with anti-10A levels. For patients with end-stage renal disease or creatinine clearance less than 30 milligrams, they recommend subcutaneous heparin 5,000 units Q8. For TBI patients, enoxaparin is associated with less VTE and higher survival than unfractionated heparin, with no difference in the progression of brain lesions. The WTA recommends patients with brain and spine trauma should be initiated on 30 milligrams of enoxaparin twice daily and considered for dose adjustment by anti-10A levels. Further on point H, neither unfractionated heparin nor enoxaparin crosses the placenta, and both are considered safe in pregnancy. Therefore, the recommendations for pregnant patients are 30 milligrams daily BID and following anti-10A levels, or 40 milligrams BID if the patient is greater than 90 kilograms and following anti-10A levels. The use of DOACs or aspirin may be considered in the setting of isolated orthopedic injuries, but only if the patient declines injection with enoxaparin or unfractionated heparin. 2 DOACs are approved for pharmacologic prophylaxis after elective orthopedic injuries: rivaroxaban 10 milligrams Q-day and apixaban 2.5 milligrams BID. Trials that compare rivaroxaban and apixaban to enoxaparin demonstrate that DOACs have equal to better VTE rates with similar to higher bleeding rates. In contrast, other analyses conclude that enoxaparin has a lower VTE rate and a lower bleeding rate. Simply, more studies are needed. Low-dose aspirin may be considered for pharmacologic prophylaxis in trauma patients with isolated orthopedic injuries who decline injections. For those trauma patients started on a DOAC for pharmacologic prophylaxis, aspirin may replace DOACs after 5 days with similar prevention of VTE. Back to a reference of the flow diagram. This is an important point to screenshot or pause the video and take it all in. Point I. Adjusting enoxaparin by anti-10A peak or trough levels appears to lower the VTE rate without increasing bleeding complications in moderate to severely injured trauma patients. Trauma patients who require ICU admission, burn injuries, and surgical oncology patients. TEG with platelet mapping may help determine if a hypercoagulability is due to platelet function, which encourages the addition of aspirin to the pharmacologic prophylaxis regimen. If aspirin is added, the initial recommended dose is 81 milligrams daily, with the possibility of increasing the dose at 325 milligrams daily, depending on subsequent TEG with platelet mapping results. Further moving down the algorithm, point J. Studies have shown that patients who miss 2 to 4 doses of prophylaxis have 8.5 times higher DVT risk compared with those who have not missed any doses. The most common reason for missed pharmacologic prophylaxis is pending invasive procedures in 41% of cases. The appropriate indications for holding or altering pharmacologic prophylaxis include acute thrombus, craniotomy, spinal surgery, epidural placement, or HIT. To further explore some of these topics, acute thrombus. Trauma patients with significant injuries and gaps in pharmacologic prophylaxis may benefit from weekly venous compression duplex. For patients pending surgery, routinely holding pharmacologic prophylaxis is only indicated in brain and spine surgery. In epidural catheter placement, Patients who require an epidural catheter increasingly have interruptions in pharmacologic prophylaxis such that epidural catheter placement is now associated with an increased VTE rate. Regional anesthesia guidelines recommend a 12-hour interval between enoxaparin dose and epidural placement or removal, followed by a 4-hour to 12-hour interval before resumption. Regional anesthesia guidelines recommend a 24-hour interval for therapeutic enoxaparin before epidural catheter placement and removal, followed by a 4 to 12-hour interval before resumption. For unfractionated heparin, a 4 to 6-hour interval is recommended before epidural placement and removal, followed by a 1-hour interval before unfractionated heparin is resumed. In the case of HIT, platelet monitoring every 3 days from day 4 to 14 or until pharmacologic prophylaxis is stopped is recommended. Trauma patients who are exposed only to enoxaparin may be considered low risk for HIT and may not require routine platelet monitoring, as the rate of clinical HIT was 2.7% for prophylactic heparin compared with 0% for prophylactic enoxaparin. Next, section K is regarding IVC filters. For point K, inferior vena cava filters may be considered in the setting of proximal DVT or PE when there is a contraindication to appropriate therapeutic anticoagulation. The paper states that IVC filters should be considered to reduce the rate of recurrent PE without altering the mortality rate. Here's another look at the flow chart as we address point L. The highest VTE risk occurs during the first 3 months after injury, with approximately 1 year required until the VTE rate returns to that of the general population. Because the optimal post-discharge dose and duration of enoxaparin after trauma are not well studied, doses more than 30 milligrams twice daily should be avoided, and the duration of pharmacologic prophylaxis may be considered for up to 4 weeks after the date of admission. For those who undergo major orthopedic surgery, pharmacologic prophylaxis may be extended up to 35 days from the date of surgery. Aspirin may be initiated for post-discharge pharmacologic prophylaxis for high VTE risk trauma patients, as it has been shown to be as effective as enoxaparin with less bleeding complications and better post-discharge adherence, and is not limited by the constraints of insurance oversight. Here's a final look at the entirety of the algorithm. And thank you for listening regarding the updated guidelines to reduce venous thromboembolism in trauma patients, a Western trauma-associated critical decisions algorithm. I recommend that you read the paper yourself and make your own judgments regarding the algorithm. Thank you.